Thank you for this kind introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm thanking the organizing committee and the scientific committee for the beautiful invitation to this great city, city of sun. Is the voice clear enough? Okay. So I would like to introduce in an honor way this topic, which is a very important topic. As we see more and more cancer, an aggressive presentation of cancer, at least in our country. And we need to do something for those patients to increase the survival rate and to decrease morbidity. So that is the aim of anything you treat in medicine, especially in cancer. May I ask to shut the door, please? Okay, so I'm going to start by talking about the pathogenesis of thyroid cancer. And by the way, this talk will be pertinent to the differentiated thyroid cancer. So all the management plan will be pertaining to the differentiated thyroid cancer, because medullary thyroid cancer and anaplastic thyroid cancer and poorly differentiated thyroid cancers, they fall into a different management track. So how do we early detect this type of cancer? We're going to define what's refractory differentiated thyroid cancer, which is an advanced stage of thyroid cancer. And then we're going to explore the systemic therapy, like applying tyrosine kinase inhibitor, mTOR inhibitors, and how to redifferentiate those advanced cancers that were refractory. In the end, I'm going to talk about immune modulation, which is a very new topic in the field of managing advanced thyroid cancer. We'll touch base on that since it's still in phase 2 trial, but that's just to introduce you to the idea, since this is a great conference to learn from. So what are the risk factors for developing thyroid cancer in general? This is very important, and it pertains to our region, the Arab region field. So gender, females were found to have 3 times more cancer when compared to males. So I'm glad that we have some oncologists here. So maybe this is attributed, so this is speculation, this is not proven yet. This is only speculation and hypotheses. Could be due to the high level of estrogen in females and the presentation of multinodular goiter in females. Probably that is related to iodine deficiency compared to males. As you know, females during the reproductive age, they consume higher amount of iodine. And unfortunately, in the Arab countries, they are termed to be iodine either moderate or deficient, unfortunately. In terms of geography, Asia was found to have more cancer reporting rate compared to Europe and Americas. We've talked about dietary iodine. So iodine deficiency is a cause for developing thyroid cancer. Radiation exposure, we do see that in kids, so teenagers. Radiation exposure is a high dose of radiation exposure during childhood, so before the age of 10. It's very important. Now, what I do in my practice, I'm actually an adult endocrinologist, but I treat children for thyroid nodules and the thyroid cancer from the endocrine perspective. I do see more and more thyroid cancer and suspicious nodules in kids, 9 years old up to 14. So when we go and take history, we find that these children are exposed to many dental x-rays. This is called an environmental radiation. A dental x-ray, according to the low BMI of a child, will be considered a high dose of x-ray radiation to the kids, especially if you have children or teenagers who do a lot of denture workup, like applying braces, implantation, lots of panoramic views. This is repetitive, consecutive, high dose of radiation, so consider that. Hereditary condition, as we've heard from the previous lecture, only 20% of medullary thyroid cancer fall into the familial category. The rest are sporadic. So these were the risk factors for general thyroid cancer. But when we talk about recurrent thyroid cancer, so what are the risk factors for having recurrence in the thyroid cancer? To start off with, an aggressive pathology like tall cell variant, hobnail cell variant. So when you do histology, we do actually look at the pathology in details because that will stage your cancer and place your cancer into category of how much radioactive iodine you have to give and how much suppression of TSH you have to do. So staging will be based on pathology. So with these aggressive types of cancer, pathologically, you need to do a higher dose of radioactive iodine therapy and term them as at least moderate risk for recurrence as opposed to low risk of recurrence. So either moderate or high risk of recurrence. Unclean surgery. In our country, and I'm not sure what's the situation here, we do have, the main operating system would be a governmental hospital, but we do have a sector, a private sector that will serve patients for total thyroidectomy or thyroid surgeries. So we do receive patients with unclean surgery, non-total resection, unfortunately, and you can detect that biochemically by the thyroglobulin level, which is not suppressed. So that's why in my practice, I choose my surgeon. I choose my team, the pathologist, the surgeon, in order for us to have a reliable information before we start planning the management. So unclean surgery will leave behind residual thyroid tissues and a non-suppressed thyroglobulin level, which will be a harbor for recurrence in the future. Inadequate radioactive iodine treatment is when you dose a patient which is a moderate or high risk for recurrence with a low dose iodine treatment, like 30 or 50. Now that's another field we have to talk about now. The new guidelines, they advocate for lower radioactive iodine treatment. So you give 30 millicurie for low risk patients. But moderate and intermediate risk for recurrence, they should receive higher dose. They should receive at least 100 according to guidelines. But at our institution, we do it in a different way. We might give 50, we might give 75, and that is based on pathology, based on lymphovascular invasion, the type of pathology, if there is a positive margin, so incomplete surgery resection. So you have to plug in all these factors in order to come up with an assessment of what would be the risk for recurrence. So that is the main thing you have to do before managing, how to stage a patient according to the TNM staging. Following surgery and radioactive iodine treatment, we do suppress TSH level. So there are levels of suppressing TSH level. For low-risk patients, we do suppress we keep TSH in the lower normal range now. But for moderate and high-risk patients, we do suppress TSH level. Suppressing TSH level will prevent tumor cells, if there was any microscopic dissemination, of being stimulated and growing back again. So TSH hormone is a stimulus for any remnant thyroid tissue. And when we do suppression, we have to take into consideration, when you bring a patient for follow-up, symptoms like palpitation, feeling jittery. So consider these and reduce the dose because you don't want your patient to end up with a bad quality of life. I'm presenting this because the talk will be managing differentiated thyroid cancer and because the radioactive iodine treatment will work only with differentiated thyroid cancer, that is papillary thyroid cancer and follicular thyroid cancer. So differentiated cancers will be the talk for today, and they originate from follicular cells. The medullary thyroid cancer originates from the parafollicular cells which do secrete the calcitonin. So following medullary thyroid cancer is by the calcitonin level. Again, this is an important cartoon here. It comes in fellowship exam questions and board questions. Why? Because the available new treatment and molecules are targeting these pathways. So in thyroid tumor generation, we have what's called the signal transduction pathway or the MAPIC pathway, as you can see here. we have many molecules to target by medication. So we have the BRAF, as you can see here, the RET. So remember, RET, BRAF, these are the targeted molecules by medication. And if you block them, you stop the signaling transduction, which will lead to tumor cell proliferation and neovascularization. So cancer will, so what is the definition of cancer or local compression of cancer causing symptoms? It's the volume of the tumor cells which is increasing plus the neovascularization. We are targeting now neovascularization by the medication. Remember that. Because advanced thyroid cancer can sometimes cause bleeding, cause fistula. So you need the medication to control that as well. You've heard about bleeding into the tumor. With the new medication, you can stop that. This is a scheme representing how would thyroid cancer from differentiated benign cells would differentiate into papillary thyroid cancer. And if it was a long-standing papillary thyroid cancer, that'll lead to poorly differentiated thyroid cancer and anaplastic thyroid cancer. Therefore, early detection is not only important, we need to manage early so that you prevent the progression of follicular thyroid cancer who went into differentiated thyroid cancer from going into anaplastic thyroid cancer. So long-standing, untreated, differentiated thyroid cancer will go into anaplastic thyroid cancer. So if you take a bunch of papillary thyroid cancer, as you know, papillary thyroid cancer is the most common type of cancer. 80% of all thyroid cancers are in the form of papillary thyroid cancer. So if you study that and you apply genetic analysis, you will find that 45% of all papillary thyroid cancer will harbor the BRAF mutation. This is according to Western data from the United States. But we, in our institution, we came up with a higher rate, up to 60% of all papillary thyroid cancer harboring the BRAF mutation. And it is different in each country. So like in Italy, you do have a similar rate of around 60%. Other studies in America reported 30%. So I encourage each institution come up with their own number. And that is true for all kinds of medicine, not just thyroid cancer. Each institution has to come up with their own research, with their own data, because we are a different population. All what I'm presenting now today is from the Western world that could not be applicable to our population. So we need to come up with our own research, with our own data, because our population is different genetically and environmentally affected by different factors. So that's why it's important to come up with each institution's work. Now, according to the 2018 AJCC guidelines, pathology guidelines, all patients below the age of 55 will fall into category stage 1 and stage 2, which are stages with excellent mortality rate. That is true for early on detection and applying the appropriate treatment. So you do reach a good stage, stage 1 and stage 2, mortality-wise, if you apply the proper treatment. So how do we detect recurrence? So we perform surveillance. Surveillance is the follow-up plan post-surgery and radioactive iodine treatment. So post-primary treatment. We perform surveillance. We bring in the patient initially every 3 months, and then you can scatter that to up to 6 months, 1 year for low-risk patients. So we perform the tumor marker, which is called the thyroglobulin, and it has always to be coupled with the thyroglobulin, with the thyroglobulin antibodies. You can't test thyroglobulin alone without having the antibodies level tested. Because if you have high antibody levels, then the thyroglobulin becomes unreliable. You wait for a period of time, after which you repeat your thyroglobulin for it to be a valid result. For medullary thyroid cancer, you test CEA and calcitonin along with each other. Unfortunately, anaplastic and poorly differentiated thyroid cancer, they rarely secrete thyroglobulin. So therefore, we do not rely on thyroglobulin for detection of advanced anaplastic and poorly differentiated thyroid cancer. However, some amount is already secreted there, and it would be there all the time, small amount. And therefore, in this case, you follow the trend of the thyroglobulin, not the absolute number by itself. Along with the blood test, we perform ultrasound and other imaging modalities. But ultrasound is the mainstay modality for detecting early recurrence. It's non-invasive, cheaper than other modalities, and readily available. And it is sensitive for superficial lymphadenopathies and certain levels, in the neck, like level 2, 3, and 4. For deep lymph nodes, you perform a CT scan. It will detect the deep lymph nodes and level 2, level 1, if there is a recurrence. Because ultrasound are not good to detect lymph nodes in these areas. Whole body scan, we perform only if we know that the thyroid cancer tumors are still in the differentiated stage. So whole body scan, I'm hoping that we have in the crowd here nuclear medicine people. So whole body scan, which is an iodine scan, a diagnostic scan, picks up any thyroid tissue, whether it's a residual thyroid tissue or a disseminated thyroid tissue which has been termed as metastases. It's very sensitive. PET scan we perform only if you have discrepancy between thyroglobulin level and the imaging. So for example, positive thyroglobulin and negative imaging. So there is cancer somewhere, but I can't detect it by the whole body scan, and therefore we perform a PET scan. If it lights up with high uptake, then you know that this uptake is cancer. And in this case, it would be thyroid cancer because you're dealing with that patient with a high thyroglobulin. Be careful. Sometimes if a positive PET scan doesn't mean always thyroid cancer. It is cancer or severe inflammation. So this is another differential diagnosis for a positive PET scan. Look at the whole condition and don't let other imaging mislead you into the diagnosis. So always perform a holistic approach when you diagnose cancer or recurrence. So what about therapy? For advanced thyroid cancer, we have to apply surgery. We have to explore surgery again. If patient has underwent a total thyroidectomy plus lymph node dissection, and if the recurrence is there, we perform surgery again. We have to clean the area before applying other systemic therapy. So explore surgery again. Second, 3 times, we do have patients who have performed 4 times neck surgeries. Of course, it becomes difficult. The neck is not virgin anymore. This is a revision surgery. You have adhesions. That's why we discuss always that with the surgeons in an MDT setting. We perform what's called an MDT setting. It's a multidisciplinary thyroid cancer, like a forum. We discuss all the options with the surgeons, pathologists, the radiologist. You have to take their opinion and to see whether they are able to go back again and clear whatever is there or not. You don't want your patient to end up with complications, recurrent laryngeal nerve complication, hypocalcemia, severe hypocalcemia, which will get the patient to live on calcium, vitamin D3, and alpha-calcitriol. Following surgery, second time, you perform radioactive iodine treatment, which is very powerful to kill any leftover cancer cells. So apply these treatments, surgery and radioactive iodine treatment. For refractory cases meaning refractory to radioactive iodine treatment, we go back and think now about systemic therapy that people are talking about. It is the tyrosine kinase inhibitor, mTOR inhibitor, or immune modulators, which is called immune checkpoint inhibitors. Medullary thyroid cancer management by Ali Zahrani has mentioned some of the tyrosine kinase inhibitors. But we cannot perform that unless you explore surgery and radioactive iodine treatment. What about resensitization? This is a new field which has came up 4 years ago. You explore resensitization by providing another dose of radioactive iodine for cancer patients where they were radioactive iodine resistant. We still have more to go. Okay, we'll try to summarize that. Okay. Can you put up? Okay, I'll go. So surgery always has to be explored. That's to do surgery either in the neck or think about any lung, liver metastases. You can do lobectomy in these cases before you apply your systemic therapy. So what is the definition of refractory radioactive, refractory thyroid cancer? Either thyroid cancer cells that are not, I'll just skip some slides, cancer cells that are not concentrating radioactive iodine, or cancer cells that used to be avid for radioactive iodine but they're not longer anymore, or radioactive iodine is being concentrated in some parts of the cancer, not all parts, or progression of the disease despite providing very high dose of radioactive iodine. These are the new guidelines, definition according to American Thyroid Association guidelines for treating thyroid cancer. One of them will be considered enough to term the cancer refractory. So refractory, in this case, we cannot apply radioactive iodine. We have to think of other therapies. So what are the other therapies that we have? We'll talk about kinase inhibitors. We have what's called multigraded kinase inhibitors. Before you start that, you have to test your patient genetically. This is a must now. In the past, it doesn't have to be the case, but now it's a must. We'll explain why. If the mutation was not identified, you test the patient and no mutation was identified, you apply lenvatinib. Very efficacious, has an anti-angiogenic property and a good survival rate. So you throw in lenvatinib blindly. This is a systemic analysis, again, elaborating the fact that lenvatinib is a very effective. As you can see, many trials have shown that the lenvatinib was favored for. If the mutation was identified, just maybe one slide. Okay. So if the mutation was identified, you apply either silpercantinib or lerotransib according to the mutation. So therefore, mutation analysis becomes very important. There are criteria to start the kinase inhibitors. So we can go over that sometime later on, or you can email me with the questions. But in summary, we have to explore surgery first before we apply our systemic therapy. So remember that in differentiated thyroid cancer, they do progress and they become dedifferentiated, and that's why you cannot apply radioactive iodine therapy, and hence the need for systemic therapy. So by that, I end up my talk, and we're happy to answer any questions in the discussion part, and thank you again for the invitation in this great city.